Good evening, everybody. Thank you so much for joining us tonight. We have the honor of welcoming Dr. Daniel Moreira from St. Jude's Children's Research Hospital. He received his medical degree from Tecnológico de Monterrey and completed his residency in pediatrics at Cincinnati Children's Hospital Medical Center after he completed his postdoctoral training at MD Anderson. Subsequently, he completed a fellowship in pediatric hematology and oncology at Children's Hospital Colorado, followed by global pediatric medicine, pediatric neuro-oncology fellowships at St. Jude's Children's Research Hospital. He currently serves as Director of Global Professional Education at a Global Pediatric Medicine Department at St. Jude's, and he will discuss pediatric oncology tonight with us. Thank you so much for being with us tonight.
Oh, thank you for the introduction, Nicole. Welcome, everybody. So I'm going to hopefully touch on some of the key concepts related to pediatric cancer care across the world. And as Nicole was saying, I'm based at St. Jude within the Department of Global Pediatric Medicine, which is basically our global health academic department. Clinically, I do neuro-oncology. So I'm attending in the neuron clinic. See, so these are really the three themes to be covered tonight, and I'll try and pay attention to the chat. If there's anything that's unclear or that I breeze over, please feel free to put in the chat seeking clarification, or if people have their mics enabled, feel free to just jump in and interrupt me. But these are the three things, hopefully to be covered in the next 15 minutes or so. There's quite a bit of slides, so there's some that we'll just pass quickly. But pediatric oncology in the context of global health, the current situation of pediatric oncology across the world, and then some of the key concepts related to strategies to improve outcomes and access to care. Just as a brief introduction, I'm sure people have seen advertisements for St. Jude, either on TV or when you buy something at the mall. But St. Jude was founded in 1962 by Danny Thomas. He was a Hollywood actor, and he basically built a hospital for catastrophic pediatric illnesses, and it was built in Memphis, Tennessee, not because he had a connection with the city. He actually grew up in Chicago, but as a message for equality. And the kind of the motto of the hospital is that no child should die in the dawn of life. And that was basically the motto that the hospital was built around. It is a hospital that provides mainly cancer care. So it's about 70% pediatric oncology. And then there's also benign hematology, infectious disease. Everything is free of cost, including care itself, but also housing and food for families. So what you see in the ads on TV is actually true. And then kind of building on this mission of St. Jude as an institution, obviously, when we think of no child should die in the dawn of life, that's independent of where they live. So the hospital founded in 1962, and about 30 years later, in a more informal way, the International Outreach Program, IOP, was born, and this was more of a humanitarian engagement in global health, more twinning models, working one-on-one, St. Jude with institutions, mainly focused in Central America. In 2016, the new institutional strategic plan came in, and this was basically prioritizing global health as now at the institution level. So that led to the establishment of the Global Pediatric Medicine Department, and then 3 years after that, the launch of St. Jude Global, which is the actual global initiative for St. Jude. And then based on that, after a couple of years of kind of discussing and kind of leveraging the importance of the institutions, St. Jude was defined as the first WHO collaborating center for childhood cancer. Basically, the St. Jude Global Program focuses on three main pillars: education, capacity building, and research. And basically, this transformation from this humanitarian structure from the 1990s to more an academic department in the past 5 years has led to the expansion of our reach. We are now engaged in 7 different regions and in more than 100 programs or institutions across the world, as you can see in this figure. So that's kind of some of the details of what St. Jude Global is about, and kind of to some degree the backdrop on some of these concepts that we'll be discussing this afternoon. So now we'll go into this first idea of where does pediatric oncology fit in global health. And when we think about global health, historically, we think about communicable diseases, right? Thinking about TB and malaria. And when we think of health priorities from the system level and from public health, usually we concentrate on, or institutions, government, ministries of health are concentrated on communicable disease. And that means vaccination strategies to get clean water. And then below that, in terms of hierarchy, are non-communicable diseases, obviously based on prevalence and importance. We have heart disease, diabetes, obesity, and cancer. And really, pediatric oncology doesn't really feature historically in this. But as we think about the development of health systems across the world, non-communicable diseases are gaining both relevance and importance in terms of health policy and system-based thinking. As a refresher, hopefully for the majority of people, this is a concept just that we'll touch on in the next couple of slides, is DALY's, disability adjusted life years. And basically what this is an addition of years lost to disability and years of life lost. So this is premature death, but also the disability factor. And this is a parameter that is sometimes calculated to evaluate the burden of disease. And this is really the main parameter that the Institute of Health Metrics uses from the University of Washington. So when we think at the global level, we see, and this is kind of in those figures on the right, is that non-communicable diseases are becoming more of the health priority. And this is independent of World Bank groups, or is it high income, or is it low resource setting? Ultimately, you see, based on kind of that these curves on the downward trend, that communicable diseases are becoming less of a burden on health across the world. And that means that communicable diseases are becoming more prevalent and more of the kind of priority for ministries of health and government. Within communicable diseases, non-communicable diseases in all World Bank groups, these contribute a significant proportion of deaths. And this we see kind of in these figures on the right. If we divide countries by their World Bank group, we see that that red component, non-communicable diseases, is really becoming the main contributor of deaths across the world. This is only really not seen in low-income countries, as you see in that kind of bar graph on the left. And then when we think about cancer, it's a major contributor to deaths of non-communicable diseases. And this is obviously more prevalent in adults, as you see at the top. And you see on the x-axis the different age groups, and on the y-axis the number of deaths per million. So we see that cancer is a public health problem, obviously more skewed toward adults, but we can't negate the fact that children also get cancer. Then when we think about the Sustainable Development Goals, or the SDGs, Goal 3 is ensuring that healthy lives for people of all ages. And then 3.4 is that by 2030, that we reduce premature mortality from non-communicable diseases by a third. So this is kind of the overall scope of non-communicable diseases. Then here's another pause for another definition. This is the Human Development Index, or HDI. And this is really a composite score of a couple of different factors, including life expectancy, education index, and GNI. So when we think about dividing countries and dividing regions, we frequently concentrate on just GNI, which is a World Bank group, but this HDI is a more comprehensive value. And when we see country trends over the past really 40 years, we see that the HDI of countries really across the world is increasing over time. So here we have really a development transition, but also at the same time, there is a demographic transition. This is probably not a novel concept for anybody, but we see this changing in the structure of the demography of countries really across the world. So going back to this concept of HDI, there is a correlation of HDI with the incidence of pediatric cancer. This to some degree makes sense, right? If we have a low HDI, there is a higher risk of communicable diseases, less patients at risk of developing cancer. So we see here with a higher HDI, the cumulative risk of pediatric cancer goes up. So very briefly, we talked on really two components, right? There's the epidemiologic transition, which means higher prevalence of communicable diseases. And then there's the demographic transition, which means there are more children and adolescents at risk of developing pediatric cancer. So putting these two things together, there is this kind of theoretical basis to anticipate a higher burden or more cancer cases in children. And actually, if we look back over the past 30 years, we see that there is actually data to confirm this. And this we see compared to 1988, or comparing 2017 to 1988, there was about a 15% increase in pediatric cancer cases. And this is based on two big studies spearheaded by the International Agency of Research on Cancer, which is one of the WHO organisms. So we see that this theory of demographic and epidemiologic transition leading to more cases, we see that there is some data to back that theory up. What the future predicts is hard to know. And then the other thing is, in terms of this DALI concept, where does pediatric oncology fit within cancer in general? We know that pediatric cancer is about 100-fold less prevalent than adult cancers, but where does it fit in terms of DALIs, right? And we think that that's disability adjusted life, but also years lost. So we see that pediatric cancer, we see kind of in that 6th rank that is actually contributes a significant portion of DALIs, ranking higher than esophageal cancer, pancreatic cancer, even cervical cancer. So this is where it fits on terms of the relative relevance compared to other cancers. So then we think of it really, where, going back to this figure in terms of the pyramid, where does it fit in terms of the health priorities of countries and regions? So we hear that, I think, in this kind of first section, that non-communicable diseases, and that includes cancer and pediatric cancer, are becoming and will become a main health problem. And here, the other point is that the importance of children with cancer in the health of population has increased over time, and with this epidemiologic transition away from communicable diseases is also projected to continue to grow. Okay, and we'll go now into our second topic. Anybody has any questions, feel free to jump in within the chat or just interrupt me, as I mentioned previously. So pediatric oncology, if we think about it as a field, is really a story of success. If we think back to the 1960s to the 1970s, the vast majority of children who developed cancer did not survive their disease. And that is vastly different from the reality right now. We have this kind of concept that more than 80% of children with cancer can be cured. And this is built on understanding the biology of pediatric malignancy more. In terms of therapy, multimodal and risk stratified treatment is a key concept for current cancer therapy. Multidisciplinary care is obviously something that is very relevant, more so for solid tumors and brain tumors. This basically is built on access to surgical capacity, chemotherapy, and then also radiation. And then understanding that cancer therapy predisposes patients to clinical deterioration events, supportive care is obviously essential, and access to supportive care is essential. And then as a field, if we think that pediatric cancer cases are quite rare, the field has progressed built on multi-institutional and international clinical trials. So this figure to the right is actually the experience of at least the first 15 studies specifically for ALL that were led by St. Jude. So we see that they're called total therapy. So we see total 1 through 4 is that bottom line, bottom line in the Kaplan-Meier. So 1962 to 66, we see that the overall survival was just about 20%. But going forward to total 15, which was enrolling between 2000 and 2005, is now closer to 96%. So this is the story of success of pediatric oncology. And that figure was for ALL, but we've seen the same phenomenon for other tumors. Medulloblastoma on the left and ependymoma on the right. These are brain tumors that we see frequently in children. Just as a brief pause, kind of in this historical kind of nature, this is just a book that I think captures a lot of the historical context of the advances of pediatric oncology. This is a really good book, and I read it during residency, and I think it was very interesting. So just a brief pause for reading recommendation. And then just to really put things into context, when we say 80% of children with cancer can be cured, this is more of a hypothetical concept. This is when we have access to all those elements, right? Multidisciplinary care, supportive care, access to clinical trials. This is that 80% of children can be cured. So we'll go into what this actually means in the next couple of slides. When we talk about cancer, and obviously this is not specific to cancer or pediatric cancer, there are two important variables to describe. One is incidence, and then the other is survival. So a lot of our data focuses around these two variables. When we think about the progression of a child with cancer, there's different steps, right, in terms of the diagnosis, the evaluation, the treatment, and follow-up. So if we think about this continuum of care, a patient with cancer will develop symptoms, will eventually be engaged in the health system, and somebody will think, well, this could be a malignancy. That person will have suspicion. That'll route them towards an evaluation, hopefully eventually a diagnosis, but not just any diagnosis, but the correct diagnosis. Hopefully that will lead to correct treatment, eventually cure, and important, not just cure for cure, but cure with good quality of life. So going back to those key variables, if we think about incidence, those first 4 steps will lead towards the data required to calculate incidence. And this is based on the availability and existence of population-based cancer registries, which are fairly prevalent in high-income countries. And then the kind of steps 4, 5, 6, and 7 would contribute to survival, again, based on the availability of population-based cancer registries. Then finally, when we think about DALYs, which is this other variable that we mentioned a couple of slides ago, we add that element of quality of life, and what are the disabilities associated both intrinsically from the cancer and then from the therapy itself. So this is something that is still a fairly novel area of research within the field of pediatric oncology. So we're going back to this that first variable, which is incidence. What is the incidence across the world? And this is data from a study published in Lancet Oncology, which is IICC3, International Incidence of Childhood Cancer, in its 3rd iteration. This is based on more than 200 population-based cancer registries from across the world. And basically, in children aged 0 to 14, the incidence of pediatric cancer is about 140 cases per million person year. But if we see in that figure on the right, there is a marked variability in the incidence. If we look at North Africa compared to Sub-Saharan Africa, then we compare those to the European regions lower in the figure, we see that there's a marked variability, anywhere from 50 to almost closer to 200 cases per million person year. And there is data published from more than a decade ago that some of the variability of this incidence correlates with macroeconomic variables such as GNI or under 5-year mortality. So then when we kind of getting at this point towards this variability, if we think about the world in general, there are anywhere from estimates that say there's 200 to 300,000 children diagnosed with pediatric cancer across the world. And then importantly, the vast majority of these cases, 80 to 90%, reside in low and middle income countries. And then when we kind of, this recurrent theme of this kind of recurrent concept of low and middle income countries, why is that relevant? The World Bank divides countries based on GNI, which is very similar to GDP. And when we think about this division from the World Bank, the importance here in terms of health and access to care is there's a very close correlation between GDP per capita and then health spending per capita. So that's why there's a very close association between these variables we see in that figure on the right. When we mention these 200 to 300,000 cases per year of pediatric oncology, these are really estimates based on the availability of registries. These figures are from a study from a couple of years ago that modeled some of the incidence data that we have and included other factors to estimate that there are about 220 cases diagnosed per year of pediatric cancer, but actually closer to 400,000 children that actually develop cancer. So that means, kind of in simple terms, that 50% of children with cancer are actually never diagnosed. So that 50% will definitely die from their disease without the confirmation of a malignancy. And we see that on the figure on the right that there's a significant variability, again, based on region. But ultimately, heavily burdened towards low and middle income country, there is that underdiagnosis phenomenon. So that's kind of the incidence component. And then now in terms of survival, this is data from the Concord group based in London. And they used, again, population-based cancer registries to calculate the survival of 3 pediatric cancers. But here we see the data from ALL. So at least for pediatric acute lymphoblastic leukemia, which is the most common malignancy in children, we see a marked variability. In high-income countries, the survival for pediatric ALL is anywhere from 80 to 90. If we see the multi-institutional clinical trials, it's up in the realm of 90 to 97 for standard risk ALL. But if we compare that to LMICs, that is significantly different, because in LMICs, it's closer to 50 to 60. And this is in the countries where we have data that are included in the study. But if we think about the penetration of cancer registries, really less than 15% of children with cancer are covered by a population-based cancer registry. So we assume that those children that are not captured by registries, where their systems are less well equipped, survivals are probably lower than that 50 to 60%. And this is the idea of variability of survival based on macroeconomic variables. So on the x-axis, we see annual government spending on health. On the y-axis, we see 5-year survival as a percent, and we see that there's a clear correlation between these two variables. So higher health expenditure, there's a higher incidence. Higher health expenditure, there's actually a higher survival as well. All makes sense. This is probably true for a lot of diseases, but this is all specific to pediatric cancer. So when we think about kind of further developing some of these concepts, so when we think about the children across the world that develop cancer, how many are cured? And this is the continuation from the study that we mentioned a couple of slides ago. This is calculating overall survival from pediatric malignancies across the world. And we see that there's significant variability based on the color intensity, and basically at the end of the day, this study modeled data from cancer registries, including other factors, and estimated that across the world, the overall net survival at 5 years for pediatric cancer is only 37%. So kind of putting all these different pieces together, yes, pediatric oncology is a field of and a story of success, but is also a story of disparities, right? That is really ultimately the most important takeaway point that we see in the field. And if we kind of dichotomize countries in this low and middle income group versus high income group, 80% of the patients who develop cancer are in low and middle income countries with a less than 40% survival. In high income countries, we see a burden of about 20% and more than 80% survival. So this is where we see the disparities of the field of pediatric oncology. And then a main kind of takeaway point, and if you remember, we mentioned risk stratified therapy, and this is based on the risk of relapse, but ultimately biology is not driving survival in pediatric oncology when we think about it as a disease across the world. The most important prognostic factor for a child that develops cancer isn't anything related to biology. It is the country where they live. That is the most important factor related to their possibility of survival. So when we think about that slide from a couple of minutes ago, that 80% can be cured, really the reality is that more than 60% of children are not cured. So these nice curves that we see from multi-institutional clinical trials are not the reality of the field and not the reality of the children who develop cancer. So when we think about how do we improve treatment, how do we include access to diagnostics, how do we improve access to treatment, we have to obviously be thinking about the different elements from a health system standpoint that contribute to all these different factors. So what are the barriers for children with cancer in low and middle income countries? This is to some degree kind of a conceptual or environmental model of cure. If we walk through the figure going from left to right, if a child develops symptoms, they'll engage in the health system, eventually finally see somebody, a physician, a community health worker, a nurse, whoever that may be, who finally thinks that their symptoms or clinical picture are consistent with pediatric malignancy, eventually based on capacity for referral, access to specialists, and access to diagnostic resources, will hopefully end up with a pediatric cancer diagnosis. After we have a diagnosis, then hopefully we have the necessary infrastructure to provide care. For pediatric cancer in general, there are three main modalities of therapy: chemotherapy, surgery, and radiotherapy. So hopefully we have access to those three, and building on the access to supportive care, hopefully we have good outcomes, and that is based on survival, but also quality of life. And this is all kind of in the universe of the health systems, of the competencies of physicians, nurses, and those providing care. So this is more of a hypothetical model, and we'll start to get some of the more specific elements that are related to pediatric oncology. So when we think about pediatric cancer care in resource-limited setting, we mentioned this idea that 50% of children who develop cancer are never diagnosed, and there's market variability. So we see in high-income countries, close to 6% is assumed to be the underdiagnosis component of pediatric oncology. But if we move towards low-income countries, it's more than 50%. So this is the reality of the field. So one thing is underdiagnosis. The other issue with pediatric cancer care research limited setting is late presentation or delayed diagnosis. And this is related to decreased access to diagnostic infrastructure, but also fragmented health system. That somebody may have the suspicion, but that patient never arrives to a facility that can actually diagnose them. They're somehow lost within that referral network. What does this ultimately lead to? Advanced staging at diagnosis. And this is that 50% that are diagnosed. So that's where you'd start to see where these poor outcomes are actually coming from. So advanced stages obviously means less likelihood of cure and less likelihood of good outcomes. The other thing that is kind of very relevant for pediatric oncology is treatment abandonment. Just because patients have a diagnosis and start treatment doesn't mean that they will complete treatment. So treatment abandonment is a big thing in the field, and we see that there is a marked variability of the frequency of treatment abandonment. This is also correlating with the level of resources. So in low resource setting, treatment abandonment is more prevalent. And if we think about what it means to treat cancer, we can see why it's a massive impact, not just for the children, but for the family nucleus. If we think about, for example, ALL, the most common malignancy in children, treatment for ALL is intense for about 6 months, but maintenance therapy for ALL is anywhere from 2 to 3 years. So for 2 to 3 years, a child in, for example, in El Salvador has to go to the clinic that may be 6, 10, 12 hours away or a couple of days travel. And so this is why we see that treatment abandonment is a massive phenomenon for pediatric oncology. And a child who abandoned obviously has a very, very high likelihood of relapse and ultimately succumbing to their malignancy. The other thing that is very prevalent in resource-limited setting are comorbidities. Malnutrition is one of these. So in the pediatric oncology patient population in low resource setting, the prevalence of malnutrition is anywhere from 50 to 70%. Malnutrition also increases the likelihood of cancer-directed therapy toxicity, altered pharmacokinetics for the chemotherapy agent, and ultimately these contribute to less survival. So these are the different elements we see that are really adding up to higher likelihood of poor outcomes. Then the other thing is, kind of factor number 5, is the less availability of chemotherapy agents and less availability of supportive care. So when we think about specifically chemotherapy, there is less availability of the chemotherapy agents, number 1, and this is really a massive issue. Obviously, it depends on multiple factors. There's the development of agents, there's the frequency of their use for pediatric malignancies in comparison with adult cancer. We use agents that were discovered 30, 40, 50 years ago that are still used for pediatric cancer patients, but are less commonly used for adult cancer. So that really means that the market for use is significantly less. So drug companies really have no interest in developing and producing, manufacturing, distributing these agents. So that's a big thing. And then thinking about that as well is not just the production, but what are the quality controls? So we have less available chemotherapy, and the ones that are available, there's questionable quality. This all leads to significant issues and impact on outcomes. In terms of supportive care, depending on the resource setting, death from toxicity of therapy is anywhere from 15 to 25%. In high-income countries, it's less really than 3%. And then when we think about additional elements of supportive care, blood bank is very important when you give chemotherapy. We're obviously inducing marrow suppression and the need for blood and platelet transfusion, so that if access to blood banking is an issue, then this really limits the intensity of therapy that we can give. And then what the last things to mention is the the access to palliative care. And this is really not so much for survival itself, but quality of therapy and quality of care. If we have less palliative care specialists, that obviously impacts symptom management during therapy, symptom management during end of life. If we have less palliative care specialists, there may be less people advocating for the access to opioids. This we know from different regions of the world. So it's not just outcomes in terms of survival, but outcomes in terms of quality of life during therapy and at the end of therapy as well, and at the end of life. So all these things add up in terms of what is the access to treatment for children with cancer. This is basically what are some of the numbers and what it looks like when we compare high-income countries and low and middle-income countries. So high-income countries are on the left. So if we kind of go through these bar graphs, we see that if we have, say, 100 patients that develop cancer, the majority will be diagnosed. The majority will receive the correct diagnosis. Those that are diagnosed will start therapy and complete therapy. There won't be a risk of abandonment. The death from toxicity is fairly low. And then obviously there is always a possibility of relapse, but ultimately, when we have all systems in place and we have access to all the resources, this is where we hit that 80% survival. This is in high-income countries. On the counterpart, if we think of low and middle-income countries, if we have 100 patients that develop cancer, maybe 20% will be diagnosed. Of those 80 that are diagnosed, there's a proportion that were incorrectly diagnosed, a proportion that will not start therapy. Those that start therapy, there's a risk of abandonment, and those that complete therapy, obviously there's still a risk of cancer-directed therapy mortality, and there's a risk of relapse. So this is kind of more of a conceptual model, but this is where we reach that 20-30% of survival in low and middle income countries. So this is just one figure that puts together these disparities in terms of access to diagnosis and quality of care. So kind of this second block's conclusion is two things. Most children with cancer live in low and middle income countries where the health systems that are in place limit access to diagnosis and limit the access to treatment. And ultimately, more than 40% of children with a curable diagnosis will die from deficiencies based on health systems. So these are patients who are curable from the biologic standpoint, but who are dying because of deficiencies in the health system, deficiencies in access to care and diagnosis. So we'll go really into this last component, which is really, well, what can we do about this? These are, I've kind of gone over some of the deficiencies, some of the issues, but what can we do about them? This is obviously a very narrow field, pediatric oncology, right? But how can we provide better care, and how can we provide better treatment for this fairly rare diagnosis? And if we think about the field in general, pediatric cancer is to some degree getting the limelight of policymakers. And the ultimate example of this is in 2017, the WHO published their guideline in terms of cancer prevention and control. And for the first time, this was 2017, there was mention of patients of all ages. So for the first time, children and adolescents were specifically mentioned by the WHO in terms of cancer care, cancer control, and cancer policy. So this is a clear example of how things are changing. Taking one step back, when we think of health systems, the WHO proposes 6 building blocks. Number 1, service delivery. Number 2, health workforce. Number 3, health information systems. 4, access to essential medicine. 5, financing. And then 6, leadership or governance. So these are, to some degree, artificial divisions of a health system, but really it helps with how we think about interventions for the future. So using this framework of the 6 building blocks, we'll kind of identify some elements that we can consider optimizing for pediatric cancer care. So when we think about service delivery, this is really the interface between the patient, the provider, and the institutions. For pediatric oncology, we have to think about how we optimize that access to diagnosis and access to care. We can think of, for example, in small countries, that there are multiple institutions providing cancer care for children. We have to centralize things, but there has to be a network of shared care, a network of referral and counter referral. So these are the things that we have to consider in terms of service delivery. And when we think about the available resources, are we really to be providing curative therapy for all children with cancer? This is obviously something that is controversial, but we have to think about possibilities of cure in the realm of research limited setting. If you have, for example, here an example that we see at the very top, high-risk neuroblastoma in high-income countries, the possibility of cure is only 55 to 65%, and that is reliant on all chemotherapy agents being able to do tandem bone marrow transplant, radiation, access to surgery, all these things. So if you think about low resource setting, are you really to invest in therapy for high-risk neuroblastoma, or do we concentrate on the patients that can actually be cured? This is obviously controversial, but these are concepts that we have to think about in terms of optimizing resources. In terms of human resources, this is obviously a key component. When we think about kind of human resources and the health system, we have to think about how that relates to education systems. Ultimately, when we think about medical education and training programs, the end objective of these programs has to be creating the competencies in the healthcare professionals to solve the problems of the health problems of the population. Right, so this is something that we have to think about. How do we train and how do we educate the needed healthcare providers to diagnose and provide care? And this is something that is very complex, right? There are multiple elements that we have to consider. Who are the pool of people to be trained? How do they get engaged in the labor market? How do we provide sustenance? How do we make sure that there isn't brain drain? This is obviously a very complex problem, but we can't forget about it, specifically for pediatric cancer and how we can impact access to care and access to diagnosis. So these are obviously things to consider. And on that figure on the bottom is work that we've done at St. Jude, where we see that by training additional providers, we are actually leaving a footprint on access to care. So we see the line on the left is the number of providers that exist in Central America. This is a regional analysis. So we see that there's a clear correlation of that red line with the one above it, which is the number of new cancer cases in the region. So we see that there's a clear correlation. If we invest in education and training, will impact the number of patients that are eventually diagnosed and hopefully survive the disease. The third element to think about improving access to care is information systems. I mentioned previously that access to population-based cancer registries is very relevant for pediatric oncology. We need to know how many cancer cases are diagnosed, how many are we suspecting based on the population at risk, but this is all based on having these registries. And if we think about the world entire, less than 15% of the pediatric cancer population are captured by population-based cancer registries. So we have to think about strategies to capture these patients. That way the field can go to policymakers and really use that data to leverage investment in care for pediatric oncology. Then the other thing, kind of building blocks 4 and 5 are access to medication and financing. And I think here's where we have to think outside the box, and how can we leverage existing frameworks, existing infrastructure, existing institutions to provide access to the essential medicines for cancer-directed therapy. And here I put one example two examples, the Global Fund and also the PAHO Strategic Fund. And this is basically a strategy of pool procurement, centralizing acquisition, distribution of chemotherapy agents for pediatric oncology, just because they are obviously a very small proportion of the patients that ultimately will need chemotherapy agents. So these are the elements that we can think about. These are strategies that we can think about for amplifying the reach of essential medicines for care. And then finally, in terms of governance, really governance is a wide concept, but this is where really influencing ministries of health is very relevant, and coming back to that idea of times are changing, and the WHO has finally included not just communicable diseases, not just cancer, but pediatric oncology in their strategies is very relevant. So this is the cover of the Cure-All framework, which is an initiative of the WHO, a framework to increase access to care. It's part of the WHO Global Initiative of Childhood Cancer. This is basically a manual for ministries of health, for policymakers to consider strategies to basically provide more robust support for pediatric cancer patients. So this is where the governance kind of fits in. And I'll just mention at this point, the WHO Global Initiative for Childhood Cancer. And this is ultimately setting a bold target for 2030, and that is doubling the cure rate for children with cancer, ensuring that at least 60% will survive, and this will ultimately lead to about 1 million lives saved. And this is between basically now 2021 and 2030. So this is kind of the investment case from the WHO. This is a collaboration with St. Jude and a number of academic institutions across the world. Okay. And then just very briefly, the Global Initiative for Childhood Cancers, kind of to reach that 60% using 6 diseases as tracers for pediatric oncology as a whole. So there are 6 diagnoses which have been identified: ALL, Burkitt's lymphoma, Hodgkin lymphoma, retinoblastoma, Walden's tumor, and low-grade glioma. And there's reasons why these 6 diseases have been picked. They're either common worldwide, for example, for ALL, common in low-income countries like Burkitt lymphoma. Hodgkin lymphoma is significantly prevalent in adolescents. So here we're kind of capturing that AYA cohort. And then retinoblastoma, this is very relevant for that idea of timely diagnosis and late diagnosis. Walden's tumor here is the multidisciplinary care component, and then low-grade glioma is obviously a complicated thing to treat, and this is where connected health systems, connected referral systems are very relevant. So hopefully when kind of the WHO, ministries of health, governments buy into the investment case of pediatric oncology with the support of academic institutions, NGOs, hopefully these can basically synergize together to improve survival. And this is why we think that ultimately, after a big transformation of the field and understanding the biology, now we're moving to a transformation of the field from kind of the global scale, and hopefully these kind of different pieces fit together and we see that survival improvement. So just kind of a couple of points to conclude in this section. Pediatric cancer, as we mentioned, is an emergent problem in global health. Pediatric oncology as a field is one of disparities. There's that 80-20 discord of burden and survival. And then hopefully we touched on some of kind of the 30,000-foot view of possible solutions and possible ways that we can leverage institutions to increase access to diagnosis, increase access to quality care, and hopefully better outcomes. Okay, I think with just about 5 minutes to spare, These are the elements that I wanted up. I don't know if anybody has any questions or any comments.
Just on behalf of Nicole, myself, and the Global Health Subcommittee, I'd just like to thank you for taking the time to give this talk. It was certainly fascinating. And we can open up to questions now. If anyone has any, please feel free to type it in the chat or raise their hand and I can unmute you. Otherwise, I have a few. So just in terms of, I'm sure you're aware of the new WHO classification for CNS tumors. I'm just curious what your thoughts are in terms of how you see this translating to low and middle income countries and kind of a timeline you see where this will take place.
That's a really good question. I think if we think about pediatric oncology in general, I think what we're seeing is a phenomenon of increasing disparities from the diagnostic standpoint. If we see the kind of the change of the WHO classification from 2016 and going back to 2007, we see obviously the molecular insights coming into the realm of diagnostics. But I think here we have to some degree take a step back and think about what are the treatment implications, right? A lot of these granular details in terms of kind of subgroups and that sort of thing, really it's unclear what are the therapeutic implications. This is relevant even to kind of high income countries, right? And then how do we leverage this information and bridge that in terms of low and middle income countries is a really important question. I think it's to some degree hard to solve, but here the question is there room to leapfrog and use novel diagnostic platforms to some degree obviate the need of a lot of the pathology resources, right? The biggest thing in terms of kind of pediatric neuro-oncology is methylation classification. So if we think about how can we implement these novel platforms in a regional approach or kind of identifying centers that can concentrate the diagnostic capacity of pediatric, at least neuro-oncology, is that the way forward that we can actually leapfrog in that way? And then ultimately, yes, there's the diagnostic component, but what are the implications in terms of therapy? If we think about the necessary elements for example, medulloblastoma therapy, you need access to neurosurgery, radiotherapy for those above 3 years old, at least from the St. Jude perspective, and also chemotherapy. But if we can identify the patients that are at lower risk of relapse, are those the ones that we can say this is more relevant for LMICs and low resource setting where their supportive care is, can we de-intensify therapy based on the diagnostic platforms? I think these are the things that we need to hash out, obviously, and then the biggest kind of relevant to the kind of CNS classification, we're anticipating to have the new classification out soon, and kind of what are the implications of that? I think from the therapeutic standpoint, it's still to be determined.
Thank you so much. We did have a question in the chat. Is there any data about the impact of the pandemic on already fragile access to pediatric oncology care?
I don't know. Yes, Nicole. So a work kind of from the collaboration of St. Jude Global and the Pediatric Oncology Society, the Global Pediatric Oncology Society, which is called SIOP, we actually launched a survey actually trying to evaluate exactly what your question is about. And what we saw is that the COVID pandemic really had a massive impact on pediatric care across the world. This is relevant for high-income countries and low and middle-income countries. There was obviously a larger effect in low and middle-income countries. There was impact on the number of patients, new cancer patients being diagnosed. There was an impact on the access to chemotherapy. impact on the access to radiotherapy, and impact on access to surgical resources. So we see that really all of the different elements of the continuum of pediatric care were impacted by the pandemic. What that eventually means for survival rates, we obviously don't know, but all these factors put together paint a very worrisome picture. And we're still kind of, to some degree, we're very much seeing this, right? But the ultimate impact we probably won't see for another 3, 4, 5 years when we see what are the outcome effects of these new barriers.
And then it looks like we've got another question. Let me see if I can allow him to talk. Benjamin, are you able to talk?
Yeah, can you hear me?
Yes.
Perfect. Okay, first of all, thanks again. Great lecture. So you kind of mentioned and hinted at a few times that kind of the way we do things, with may not really work in these low middle income countries with the 12-hour bus ride and all that stuff. So real success might require, frame shifts and real innovation and things like that in the way we diagnose and the way we treat. Are there any inventions or innovations or new treatment methods that are being studied that you're excited about that are being studied right now?
So I think it's a really good question, Benjamin. I think what we have to think about, and this is something that we learned as a field probably 15 to 20 years ago, if we directly export the therapy that we use in high-income countries to low-income countries, the outcomes are very poor. And this is mainly related to intensity of therapy and the availability of supportive care. This was the experience from exporting high-income country clinical trials for ALL, where because of the lack of supportive care, the outcomes are 20 to 30% lower in low resource settings using exactly the same treatment schemes. So this is where that innovation comes into play. And really the question is, how do we implement resource adapted therapy, one, and how do we optimize the resources that are available? I think that the thing that we have in our favor in pediatric oncology is a centralization of care. So if you think about, I don't know, Central America or South America, most of the countries have maybe 1, 2, or 3 pediatric cancer units. So by centralizing care, we can optimize novel treatment strategies. We can optimize the resources that are available. We can regionalize the diagnostic infrastructure. So we think, kind of thinking in the future, do all Latin American, and then obviously this is depending on the formation of collaborative groups, can we centralize the diagnosis of CNS tumors in children in 1 or 2 centers? You think one for Central America and one for South America. And is that really the way to optimize resources and leverage this innovation that you were getting at? And this is where kind of these novel diagnostic platforms can come into play. But ultimately, it has to be both a kind of bottom up coming from institutions and the providers, but also kind of top down in terms of influencing of the policymakers, ministries of health that really have the buy-in to invest in pediatric oncology. And a big thing that we always mention in the field is that if you invest in pediatric oncology, you're getting all these side effects and improving blood banking infrastructure, improving infectious disease and infection control institution. I think we still have to kind of create the data to really convince people, but at least in kind of this narrow field, the idea that we have.
Okay, I think that we've reached our time. I would just like to thank you again. That was an excellent lecture and generated an excellent discussion.
Wonderful. Thanks for inviting me and thanks for the opportunity. I left my emails on the screen in case anybody has any burning questions or anything comes to mind, or I'm at your disposal.
Great, thank you so much. And thank you everyone who was able to log in.
Thanks, guys.